Now we're going to see the septation of the ventricles. Here we have the right atrium, right ventricle, left atrium, and left ventricle. And here we're going to have the septation. Alright, we have the septum. The interventricular septum has two parts, the membranous and the muscular. The muscular arises from the muscle of the ventricle, that is this. It is growing from this side to the endocardial cushions. The endocardial cushions are here. So this is the interventricular septum, the muscular part, and it does not touch the endocardial cushions. Next step, this is the first step. First step, growing of the interventricular septum, muscular part. Next step is we have formed the outflow of the ventricles, that is the aorta and the pulmonary arteries, whatever. But these arise from a troncus arteriosus. These arteries arise from a common artery. So first we have a common artery that we have septation of a septum between what is going to be the aorta and the pulmonary artery. We have a septum, so we have spiral of this septum, and when this septum spirals, after that it fuses with the interventricular septum, the muscular part, and this spiral of the this arteria, this interarterial septa, this contributes to the membranous septum. Also, we have contribution from the endocardial cushions and other conotroncal ridges of the ventricle and stuff like that. But all of this contributes to the membranous part of the interventricular septum, that is the one that fuses with the endocardial fusion, and then with this we can have a ventricular septal defect if we don't develop this part of the interventricular septum, or if we don't develop this part of the membranous part. The most common is abnormal development of the membranous part of the interventricular septum. That because this is formed in part of endocardial cushions, the patient will also have endocardial cushion defect, that is neural crest defect, and this is commonly in patients with Down syndrome. Patients with Down syndrome has a ventricular septal defect, endocardial cushion defect, and many other things. And isolated also, the most common congenital defect of the heart is communication between the ventricles. Alright, so the most common is because of abnormal development of the membranous part of the interventricular septum. Now, when this happens, the blood is flowing from left to right because the pressure in the left ventricle is higher than in the right ventricle. So the baby is going to be right when we born, because he or she is not going to have any cyanosis because blood is flowing from left to right. And yes, maybe we can hear ventricular septal defect murmur, that would be holosystolic, because it's in the systole when we have the flow, is when the left ventricle contracts and sends blood through the aorta, but also to the right ventricle. So it would be an holosystolic murmur, best heard in the around the parasternal border in the left side, and in the left inferior border, the left inferior parasternal border. And we will also hear it. We will also hear the intensity and it depends on how big is the defect. If the defect is small, it spontaneously closes normally. If it is big, it needs correction. First, if we leave it like that, blood flow is going to reverse, because first blood is going from left ventricle to right ventricle, then all the way down or up, whatever. Then the right atrium is going to be hypertrophied, and so blood is reversal from right to left, and the patient is going to have then cyanosis. But this is like 10, 20 years, well, 10, more like 10 years, 12 years after birth. And also this patient would have in exercise cyanosis, because they need more oxygenation. We have the blood coming from right to left, and the patient would have cyanosis. In pre-chirurgical parameters, we have increased, obviously, the right ventricle pressure. Also, because we have more blood in the right ventricle, because the left ventricle is sending blood through here, we have more blood that is going through the pulmonary artery, and so we have also increased pulmonary artery pressure. And because we have more blood in the pulmonary artery, we have more blood returning from the venous vein to the left atrium. So also we have increase of the left atrium, and certainly of the left ventricle. When we have, well, this was obviously pre-chirurgical, and after the ventricle, the right ventricle has hypertrophied. Now is because we have the increasing pressure in the right ventricle, and when the right ventricle is hypertrophied, now blood goes from right to left, and when we have blood going from right to left, now also the left ventricle has hypertrophied. After surgery, that we correct this septal defect, the pressure of the left atrium decreases, the pressure of the right ventricle decreases, because now we don't have that much blood that the left ventricle was sending to the right ventricle. So the pressure from the the pressure of the right ventricle and of the left atrium decreases, but the pressure of the left ventricle remains elevated. This remains elevated, and an irreversible change is the changes that occur in the pulmonary artery. This is the main reason for which we correct and restart the cyanosis. But also we correct this septal defect, because we don't want that the changes occur in the pulmonary artery, because it would be intimal hypertrophy, medial proliferation, both are irreversible changes and can lead to pulmonary hypertension that in the long term could lead to heart failure.